Welcome to Radiology Made Easy. Today, I'm examining a pair of images from a barium follow-through examination, focusing on the small bowel. These images reveal an apparent solitary focal abnormality at the duodenojejunal flexure. The mucosal fold pattern is obliterated over a short segment of 3 or 4 centimeters and is replaced by a relatively featureless, smooth pattern. I notice a suggestion of nodularity inferiorly, which could potentially be food debris. The bowel lumen appears to be slightly reduced, but there's no tight stricture, and there's no dilatation of the upstream segments of the duodenum, ruling out obstruction. Even though the lesion appears solitary, I would meticulously examine the rest of the barium follow-through series for any synchronous lesions. It's particularly important to inspect the terminal ileum. If the patient has a history of inflammatory bowel disease, this lesion could represent a segment of Crohn's disease. However, I don't see any stricturing or obvious ulceration here. For patients with a history of celiac disease, especially if dietary control is poor, I would consider lymphoma, a recognized complication. Notably, the mucosal fold pattern in the duodenum and jejunum appears to be normal otherwise. The differential diagnosis for an apparently solitary mucosal-based lesion in the small bowel is broad, including both malignant and benign etiologies. These can range from adenocarcinoma and carcinoid tumor to benign conditions like adenoma, hemangioma, and lipoma, as well as inflammatory pathologies associated with connective tissue diseases or previous radiotherapy treatment. If this mucosal-based lesion is confirmed to be solitary, definitive diagnosis could be achieved through endoscopic inspection and biopsy, given that the duodenojejunal flexure is generally accessible with conventional endoscopy. I would communicate these findings to the gastroenterology team for further evaluation. Key points for small bowel barium studies. It's crucial to be confident in your knowledge when performing a barium study of the small bowel. Always consider the number of visible lesions. Multiple lesions usually indicate a benign pathology, often associated with conditions like Crohn's disease. Solitary lesions, although less common, are more likely to be malignant. Checking whether the terminal ileum has been imaged is important because it's a common site for focal small bowel lesions in Crohn's disease. Next, examine the space between bowel loops for any abnormal widening, which could indicate extrinsic pathologies. Mesenteric fat hypertrophy is often seen in Crohn's disease. If the case includes cross-sectional images, also look for enlarged lymph nodes and liver lesions, which may suggest malignancy. When uncertain about the nature of a lesion, use a structured approach to your analysis. Consider extrinsic, submucosal, mucosal, and intraluminal causes sequentially. Remember, Crohn's disease is the most common cause of focal small bowel lesions. However, the prevalence of such cases in exams often doesn't reflect real-life scenarios where more esoteric and unusual cases are encountered. It's essential to familiarize yourself with the varied manifestations of Crohn's disease, particularly through small bowel barium studies, as these can often present as long, obstructive segments confined to the pelvis. Thank you for joining me on Radiology Made Easy. Every image has a story, and I'm here to help you understand it. Please share your thoughts and suggestions below, and stay tuned for more insightful discussions. See you next time.